Today's CME program is accredited for 1 hour of AMA Physicians Recognition Award Category 1 credit for US physicians. API also welcomes our invited Indian and other international guests to this program. Please submit your pre and post surveys and use the chat line for the question and answer session. The moderator of today's program is Dr. Raj Alappan, a well-known nephrologist who is Associate Professor at Mercer University School of Medicine and Assistant Professor at Medical School of Georgia. Thank you, Dr. Alappan, for joining us today. It's now my pleasure to introduce our distinguished speaker, Dr. Vivekananda Jha. Dr. Jha is the Executive Director of Global Health, India, and a consultant nephrologist at Fortis Escorts Kidney and Urology Institute in New Delhi. He is also professor and chair of Global Kidney Health at School of Public Health, Imperial College of Science, Technology and Medicine, London, UK, and conjoint professor of medicine at University of New South Wales, Sydney, Australia. Dr. Jha is the current president of International Society of Nephrology. He holds several key positions on international and national policy making and professional bodies, such as the World Health Organization's Expert Advisory Panel on Human Cell, Confederation of Indian Industries in New Delhi. Dr. Jha is the section editor of Oxford Textbook of Clinical Nephrology and is on the editorial boards of several national and international journals and the recipient of a number of prestigious awards and honors in India and internationally. We are proud to welcome Dr. Vivekananda Jha, an international expert and authority in the field of nephrology, as our distinguished speaker of API tonight. Dr. Jha.
Thank you, Dr. Murthy. And first of all, let me start by thanking the leadership of API for inviting me to speak with you this morning, my time, and evening, your time. I am also very pleased to see some of my very old friends and colleagues, including Professor Anupam Agarwal, who is the immediate past president of the American Society of Nephrology. And it's worth mentioning that Anupam and I trained together a long time ago. And we have remained very close friends. I also would like to pay my respects to Dr. Kasinath, who I can see in the list of attendees, and I'm sure there are many more, so please forgive me for missing you. So what I'm going to do now over the next 45 minutes or so is to talk to you a little bit about the global burden of kidney disease with specific reference to kidney disease burden in India. I hope you can see my screen.
Yes.
Okay, great. And during the course of this talk, I would take the opportunity, since I'm talking to American colleagues, of contrasting and comparing some of the examples between US and India as to how things are similar, but how they're different as well, and how can we learn from each other. Okay. So let me just start by contextualizing the burden of kidney disease. So even though we are nephrologists and we talk about kidney disease, we shouldn't forget that the world's single greatest health challenge right now is to how to provide healthcare to 7 billion people who live on this world, out of which 5 billion have no reliable access to essential care, and about 2.5 billion will develop serious disease before the age of 60. So that's the context. And it's important to say this because you are a group of physicians, not just a group of nephrologists. And so we shouldn't forget that there are many other diseases with which the kidney disease intersects. But why do we talk about kidney disease? The consequences of kidney disease are multiple and varied. And we can talk about that for hours, but it's suffice to say that in this paper now, 16 years ago, Dr. Alan Goh and colleagues using data from Kaiser Permanente showed that the age standardized rate of death on the panel on the left and age standardized rate of cardiovascular events increase as the glomerular filtration rate goes down. So this was something which we now take for granted, but wasn't obvious to everyone all the time, because people thought that the adverse effect of kidney disease is development of end-stage kidney failure and requirement for dialysis. But we realize now that people can die of cardiovascular disease much earlier, and their risk of developing and dying of cardiovascular disease actually starts to rise at relatively early stages of kidney disease, which makes it important for us to intervene at early stages as well. And also, this is a figure from any textbook of medicine, and you can see the varied manifestation of kidney disease, which suggests that CKD is not just renal disease. The renal manifestations are in just one of these boxes, but CKD is actually a systemic disease. Let's look at kidney disease in numbers, and I think it's important to look at these numbers because it hits home. And I start with smaller numbers, rising numbers. So about 1.7 million people die of acute kidney injury every year around the world. Chronic kidney disease now is the third fastest growing cause of death around the world. Currently, there are about 3 million people on dialysis worldwide. But what is not always appreciated, that in addition to these 3 million, about 3 to 7 million people worldwide require dialysis every year, but they unfortunately die because they cannot afford or access kidney replacement therapy. Kidney disease will become fifth as an important cause of death worldwide by the year 2040. Currently, the global prevalence of CKD is about 8 to 10% in the population. In addition to 1.7 million who die of AKI every year, about 13 million people also develop acute kidney injury, and many may not die right away, but they go on to develop chronic kidney disease. According to global burden of disease, about 36 million disability adjusted life years annually are attributable to chronic kidney disease around the world. But an important point to mention is about 188 million people around the world experience catastrophic healthcare expenditure annually due to chronic kidney disease. And this number is greater than that for any other disease around the world. And finally, a joint project by the American Society of Nephrology, the European Renal Association, and International Society of Nephrology estimates that about 850 million people have kidney disease around the world, which puts it into context with the number of people with diabetes, which is less than 500 million. Now, let me just give you a glance of the major milestones in kidney health in India. So in 1958, the first kidney biopsy was done by my mentor and mentor of Professor Anupam Agarwal as well, Dr. K.S. Chugh, when he was a medical student. First, hemodialysis started at Christian Medical College, Vellore in 1961, and subsequently expanded to PGI Chandigarh, Mumbai, and Chennai. First peritoneal dialysis was done in 1964, and first kidney transplantation in 1971 at CMC Vellore, and then transplant program started elsewhere. The first nephrology training program started at PGI Chandigarh in 1969, and it's interesting to point out that this was even before a formal American board in nephrology had started. And you can see the other major milestones on this slide. In terms of legislative process, India passed the Transplantation of Human Organs Act that banned sale and purchase of kidneys and legalized brain death in 1994. In 2016, for the first time, India announced universal dialysis access as part of its national dialysis program. And in 2019, it included peritoneal dialysis in this program. Since then, many state governments have started supporting coverage of payment for dialysis and transplantation. And what is happening now? What is happening now is a consistent increase in demand, consistent increase in the scope and range of services on offer, more number of people being trained in nephrology. There are challenges with financing of kidney care, as well as its governance, administration. As information sharing becomes wide with broad availability of internet, communication is important, but misinformation is important as well. And of course, generation of new knowledge is taking place every day. Now, if we start with the basics, this figure shows you that chronic kidney disease prevalence is increasing in India. This is data from the global burden of disease, which compares the CKD prevalence in 1990 on the map on the left and 2017 on the map on the right. Red is bad and blue is less bad. There is nothing which is good. So you can see there is more red on the map on the right, which suggests that kidney disease prevalence has increased over time, as is mortality due to kidney disease. And this figure shows, again, in a mapped manner, age-standardized kidney failure death rates in Indian adults. This data has been taken from the Million Death Study, which tracked deaths in different states between 2001 and 2003 on the left, and 2010 and 2013 on the right. And you can see that during this period, the age standardized death rate has increased substantially, again, as indicated by a greater number of states colored red here. But as all of you perhaps know already, that the infrastructure to manage kidney failure, as it is for many other advanced diseases, is woefully inadequate. This map shows you data on the distribution of transplantation services in India. And you can see the southern states are doing better than the northern states, which are really, again, colored red and brown, which indicates low number of transplant centers in these states. And similarly, you can develop another map about dialysis services, which will look very similar. According to our studies, about a quarter of patients who require dialysis live at least 100 kilometers away from a dialysis facility, and about 50% live about 25 kilometers away. So if we step back and look at how we diagnose kidney disease, we all know, I think, as physicians, that diagnosis of kidney disease requires access to serum creatinine estimation, which allows you to estimate glomerular filtration rate on the left side, and urine testing for albuminuria, which allows you to measure how much protein one is losing. And based on these two, one can do risk stratification for chronic kidney disease. This is something which is practiced globally. However, International Society of Nephrology estimated the availability of these very simple tests around the world. And what the figure on the left shows, without going into the great detail, is the availability of serum creatinine and urine albumin creatinine ratio laboratory facilities in different countries. And on the outermost line, you can see high-income countries, and on the innermost line, you can see low-income countries, which indicates that availability of urine albumin creatinine ratio and availability of creatinine and EGFR testing at the bottom is really very, very scarce at primary care level in low and low middle income countries. So that's a big challenge for us, which often is not obvious. And so as the world debates how to develop much more accurate GFR equations, especially in United States and other parts of the world, many countries around the world which house most of the poor population are struggling even to get the most basic serum creatinine testing available for their populations. The second point I would like to make is that the acute kidney injury that you see on the United States and that you see in a country like India is very different. There could be actually two different diseases, because acute kidney injury in US typically develops in hospitals, in the elderly people who are ill with multiple other conditions, whereas in India it develops in the community because people have developed tropical infections or volume loss secondary to diarrhea, bad obstetric accidents, snake bite, insect stings. These are the important causes of acute kidney injury in India. And what happens is that when people develop this, they present really late to the hospital, and they have already developed complications, and they're in imminent need for dialysis and other kinds of kidney replacement therapy. Most of these deaths are entirely preventable, and you would actually be surprised if you saw any of these patients in your practice in US. So if we move to treatment of kidney failure, so what is the worst kept secret in nephrology? I showed you this figure already about the increasing number of people with kidney disease. So the worst kept secret in nephrology in India is that about 2.3 lakh patients need dialysis treatment every year, but only about 10% of those are able to receive it. Everyone else dies. So if you were to conceptualize kidney failure burden in India, the outermost circle indicates the entire population with kidney failure. Only a sub number of which is actually recognized. A smaller number are able to access kidney replacement therapy, and an even smaller number are able to stay on kidney replacement therapy for the long term. And this is a paper that we published in the Journal of one of the journals of the American Society of Nephrology, Kidney 360, which shows at a high level the number of kidney failure patients who in India, the number of kidney failure patients who are actually on maintenance dialysis today, the breakup of dialysis modality, 94% receiving hemodialysis, and the breakup of how people fund their dialysis. And you can say that about 50% actually pay for dialysis by themselves, and about 30% receive some sort of state funding. On the right side, you see the cost for dialysis session to the individual on the top and to the health system at the bottom. So when we think of dialysis, we have to, again, go back to American history. And dialysis around the world was made really accessible by the passage of this public law 9623 in 1972. And at that time, one of the senators argued that 60% of dialysis patients can actually be treated with only a minor degree of retraining, and about 40% can return to their original employments with no retraining whatsoever. And what this has done is that, at least in the Western countries, dialysis is universally accessible, and it is considered unethical to deny anyone access to dialysis because the resources are not available. And this is as a section that I have taken randomly from the Australian guidelines. However, soon after dialysis was started in US, within a year, people realized that dialysis is expensive, and you started seeing these kind of news items in New York Times, which talked about the passage of this public law as a chapter in the growing history of congressional fumbling with health matters and so on. It seems like we are reliving those conversations. But what has happened is that as a result of widespread access to dialysis in developed countries, many developing countries, including India, are also providing or committing to provide dialysis universally to their populations. And as I said, in 2016, the government of India announced the Prime Minister National Dialysis Program, and it's being rolled out across the country. But the challenge with this is the following. We showed using data from the Arogyasri scheme, which is an insurance scheme in the state of Andhra Pradesh. This scheme was actually launched in 2008, almost 8 years before the announcement of the National Dialysis Scheme. We analyzed the data of first 4 years from the Arogyasri scheme. We were able to show that while access to free dialysis at point of care does lead to an year-on-year increase in uptake of the number of people who are able to access dialysis, but you can see here in the graph on the right that the outcomes remain very, very poor. That 50% of the patients drop out of dialysis in about 6 to 9 months, which is terrible. You will never see that happen in a developed country. And this happens because of a number of other residual costs, which lead to catastrophic healthcare expenditure to patients and their families. This is data from a similar experience in Kerala, which also provides free dialysis. And you can see that people who experience catastrophic healthcare expenditure, which means more than 40% of their income was spent on supporting dialysis, which led to what is called distress financing. Distress financing means that they had to resort to maybe selling some of their assets like house or like one of their belongings or taking loan and so on and so forth. And you can see that the number of these individuals is in excess of 90%. Who experienced catastrophic healthcare expenditure leading to distress financing. Now, if we look at the various options that are available to people with kidney failure, according to the global nephrology community, you look at the top of this triangle, which is divided into multiple sections, and the top indicates the treatment options available to people with kidney failure. We know that kidney transplantation offers the best value for money, followed by peritoneal dialysis and hemodialysis. However, we know that peritoneal dialysis, despite being more cost effective, is actually not popular around the world, and the reasons for that can be many. This graph is taken from US RDS annual data report, in which countries have been ranked according to their prevalence of patients on peritoneal dialysis, with Hong Kong and Jalisco state of Mexico being on top. And you can see the other countries going down. India is not on the map, but we'll talk about India in a moment. So this is peritoneal dialysis in India in numbers. And what is alarming to see is the number of patients on peritoneal dialysis has been actually dropping over the years. This drop is something which requires more study and which requires to be addressed. Why is this important? This is important. Again, I go back to the American experience, and I would say that the most important driver for this differential access to dialysis therapy is financing. And US introduced the Medicare prospective financing system. The summary of the result of this study, which was published in the Clinical Journal of American Society of Nephrology, that before this prospective payment system, the proportion of patients on daytime ambulatory peritoneal dialysis and nighttime peritoneal dialysis was 9.4 and 12% respectively, which has increased over just a period of about 5 to 6 years. And in subgroup analysis, the increase in PDUs was statistically significant. There was an increase in number of patients shifting from hemodialysis to peritoneal dialysis, but there was no change in the number of people who were shifting from peritoneal dialysis to hemodialysis, which means that this reimbursement reform led to increase in the use of the treatment, which is more cost-effective and more patient-friendly. Now, as I said before, chronic kidney disease is the third fastest growing cause of death in India, around the world rather, and it will become the fifth leading cause of death in 2040 from the current place, which is 16th. This has been also again recognized by the US administration, and this executive order on advancing American kidney health was passed on July 2019, which basically focuses on prevention of kidney failure wherever possible through better diagnosis, treatment, and incentive for preventive care. And this is a phrase which all countries of the world should embrace, just as they did when the US started their dialysis service. And so that takes me to kidney disease detection and treatment. Now, we know that hypertension and diabetes are the most important drivers of kidney disease around the world, especially in high-income countries. So you have the contribution from diabetes in the section of these bars colored blue, and the section due to hypertension is colored about brown. But on the rightmost side of these bars are other causes. And it's important to point out that in low social development index countries, which includes India, there are some other causes which are also important in addition to diabetes and hypertension, which are also growing in India. So based on these data, the US Preventive Task Force actually says that in the general population, you don't need to screen or do anything to find patients with chronic kidney disease. However, patients with high risk, for example, those with hypertension, those with diabetes, those with cardiovascular disease should be screened for presence of chronic kidney disease. But let me give you some information about kidney disease in India and also in some other parts of the world which share socioeconomic and climatic characteristics with India. So chronic kidney disease hotspots have been described from around the world. And I noticed from the remarks that were made in the initial stage that you all are going to go to Visakhapatnam in your meeting, and you're going to be making a tour of a number of places there. And I will take you there to the district of Srikakulam in Andhra Pradesh, which is not too far from Visakhapatnam. It's a 3-hour road journey, and the road is very nice. And in the district of Srikakulam, there is an area called Uddanam. And in Uddanam, there have been reports of a high prevalence of chronic kidney disease in rural agricultural communities. The cause of this disease remains a mystery, and no one has been able to solve it so far. So we started a research program a couple of years ago, and we conducted a systematic study of the prevalence of kidney disease with an aim to look at the possible causes and then to find a remedy. So I'm going to show you data from this paper, which again was published a couple of months ago. We did a stratified random sampling of more than 2,500 adult subjects in Uddanam area. And we found a number of risk factors, which were older age, male sex, family history of chronic kidney disease, presence of hypertension, and tobacco use. We also found that compared to subjects who had a normal glomerular filtration rate, which meant they did not have chronic kidney disease, people who had lower eGFR were older, they were likely to laborers and farmers, they were relatively malnourished, uneducated, they had hypertension, they were tobacco users, and they had a history of heart disease. So this is something which really is for the first time something that we have demonstrated, and we need to do more. So in terms of numbers, what we found there about kidney disease in Uddanam was that in this population of about 1 lakh people, out of every 100 people, 43 were regular tobacco users, 44 used pain relief medications, which is NSAIDs, which can hurt the kidneys. 30 out of every 100 consume alcohol regularly, which is country-made alcohol. And then we found that out of every 100 persons, 42 had high blood pressure. This is amazing. And this is almost more than 3 times the general population prevalence of hypertension in Andhra Pradesh shown in national surveys. 13 out of every 100 had diabetes, which is almost double the prevalence of diabetes in rural Indian population. And 14 out of every 100 had another family member affected with kidney disease. Coming specifically to kidney disease, out of every 100, 21 had some sort of kidney disease, 20 had low EGFR, and 16 had, so 16% of the population there has proteinuria, which is amazing. And this amazing in a bad way that we need to do something about it. This is important. 42% prevalence of hypertension, 21% prevalence of chronic kidney disease, and 16% prevalence of proteinuria. And let me remind you that this part of India it falls right on the tropical belt, and we know that according to experts in this field, by 2025, more than half of the world population will reside in water-stressed area. Water is the most important culprit that people have often pointed their finger to about the high prevalence of kidney disease in Uddanam. And we are working with the state government. The state government there has made treated water or reverse osmosis treated water available to villagers in Uddanam area now, which hopefully will take care of some of the water scarcity which India is already seeing, but is going to become worse in the next few years. In addition to that, we are also in India being hit by unique challenges related to climate change. The increasing air temperature is definitely affecting already the quality and quantity of drinking water. A number of people are being forced to migrate and are being displaced because of a number of climatic changes. You all are already aware of the bad air pollution in many parts of India, and pandemics, of course, we live in that world. But also worth pointing out is the emergence of, or rather re-emergence of tropical diseases, which are transmitted by vectors like mosquitoes and ticks and mites, etc. And they are leading to emergence of new conditions. And we showed the emergence of this new condition, scrub typhus. So when I was training, scrub typhus was not known to be an important cause for any health condition. But more recently, we identified a number of people who were presenting with acute kidney injury to our hospital, which is at that time PGI Chandigarh, and we didn't know what was the cause of fever and kidney failure in those individuals. And then we speculated, we looked at the literature, and we developed a PCR assay in our lab, and we were able to identify that almost a quarter of these individuals with this unexplained febrile illness with acute kidney injury, which typically was attributed to malaria in the past, actually had scrub typhus. And the treatment of scrub typhus is really easy. You give them oral doxycycline and they get better in a matter of days. So it's really important that we know this. So then that takes me to this slide of sharing with you what we think are the current kidney disease treatment gaps. So they can be grouped into these 6 boxes: a rapidly changing disease burden. I hope I have been able to convince you that there is a large undiagnosed and untreated population. And I haven't shown you data on this, but the number of nephrologists in India is really low. And you may not be aware, and it comes as a surprise that actually the number of nephrologists of Indian origin in US is perhaps more than the number of nephrologists in India. So that's something that you might go back and think about. We have placed a disproportionate focus on curative care. There is a lack of effective, organized, community-based program for detection and treatment, and there is a lack of guideline-based care. So let me just talk to these bottom 3 boxes. And there is a lot that we can do. For kidney health, What is important? We need to control blood pressure. We need to control blood sugar. We need to advise lifestyle modifications such as increasing exercise. And there are a number of really effective drugs which are available. Angiotensin receptor blockers, statins, and more recently, SGLT2 inhibitors, which have the potential to positively affect the course of patients with kidney disease. But we need to find sustainable solutions. And so where do we start? We need to look at the workforce challenge, and we need to develop some technologies which are able to support this workforce. So we are developing a program, or we rather have a program which is working in this population in Uddanam that I described, which is a program of innovative healthcare for these disadvantaged communities. And this aims to, or rather has already developed a village-based healthcare ecosystem using digital health technology. It relies on the healthcare delivery by community healthcare workers who are drawn from within the community, who receive some sort of regional medical supervision by public sector primary care doctors. They are provided with a smartphone or a tablet device, which has a clinical decision support system built in. And we give them small point of care diagnostic tools. And using this data and evidence-based algorithms, they're able to provide guideline-based care and are under continuous quality control monitoring. So this is the way it works. So the Smart Kidney India, it's a program which the frontline healthcare worker, which are called ASHA workers in India, uses. And they have a 4-step process. They can register a patient, they take simple history, they assess risk factor for development of kidney disease and cardiovascular disease, and then finally they have a treatment advice page, and they can refer patients who need to be referred. And in this Smart Health, it already has a number of components, which starts from decision support to risk communication. It has a number of multimedia resources. It can provide workshop training to healthcare workers. It has interactive voice response to remind patients of important deadlines coming. But also we recognize that we also need to support the infrastructure in the primary healthcare centers, so it can track medication supply, it can provide government support, and also remuneration incentives to the healthcare workers. So you will ask me this question: does this approach work at all? I mean, it sounds very good in theory, but have you applied it, and have you shown that it works? So the answer is yes. So we have been working at this for the last many years now. And again, this is data from Andhra Pradesh at that time in the East Godavari district, Bhimavaram being the town around which we did this work. So the healthcare workers were given a checklist, and we asked them to go and identify individuals at high risk of cardiovascular disease using the WHO checklist. And what we found to our surprise, that using this checklist, the frontline healthcare workers actually performed better than primary care physicians in accurately identifying individuals at high risk of developing cardiovascular disease. Subsequently, we then went ahead and started using this approach for treatment as well. And again, this treatment, which was delivered by frontline healthcare workers, improved the proportion of individuals who were on blood pressure lowering medicines and who achieved target blood pressure from about 23 to 29% before the intervention to as high as 65 to 64% after the intervention, which is huge. And we published all of this experience. So at this time in Uddanam district in Palasa block, we have set up a research program. And I show you some of these pictures. And here is our senior research fellow who's training the frontline healthcare workers. And here is our health worker who is sitting and talking to a patient and developing a risk score for that patient. Healthcare workers go to people who live in this kind of sometimes very, very miserable situations, and they do the risk assessment and make appropriate referrals. So then, using this, we are hoping that we will be able to improve the kind of kidney care that these patients receive. And I'm not going to show you data on the assessment of the causality for kidney disease, but we are making progress around that as well. We have identified a few potential culprits For example, we have identified in this coastal area very, very high salinity in the water that these people consume, which of course should be addressed by the availability of water now by the government. But the water that comes in natural water sources there is very high in salt, which could be a part explanation for the high prevalence of hypertension there, as well as a higher prevalence of proteinuria. We are finding very, very high prevalence of familial clustering of kidney disease. And at this time, we are engaged in a study in collaboration with the Institute of Genomics and Integrative Biology in looking at the genetic background of these individuals, which might give us some insights into potential genetic causes. So in summary, what I hope I have been able to share with you and convince that chronic kidney disease or kidney disease in low-income countries avoids straightforward articulation, and the kidney disease that you see and you manage in US is likely to be very different in terms of its presentation, in terms of its socioeconomic determinants, and in terms of the approach that we need to take to address it. We also need to be aware of unique regional variation and very strong effect of social determinants of kidney disease. We also have been able to show very different consequences depending on where kidney disease is diagnosed, and that it is impossible to solve a kidney disease problem around the world in a way that is simple or final. And finally, articulation and management of kidney disease requires a holistic and collaborative reasoning in search of long-term future-focused solutions. So with this, I'm going to end my presentation. I'm happy to take any questions, and thank you once again for your attention to this talk and your interest in this topic.
A great informative presentation, Dr. Jha. Your contributions to enhance kidney health internationally, specifically in India, are much appreciated. Thanks again for sharing your decades of wisdom and experience in the field of nephrology. Dr. Raj Alappan will moderate the session now. Dr. Alappan.
Hello and good evening to everyone, to all the participants and Dr. Jha. It was our privilege to have you here on our CME webinar, and we owe you a bunch of gratitude, and thank you, sir, for being with us. Being the ISN president, you have a global perspective of CKD. So with that in mind, we are enlightened by your talk today. On this side of the Atlantic, I have Dr. Anupam Agrawal, as you already mentioned. He is well known to me, and also you know Kashinath. Kashi is my classmate, and Anupam Agrawal's dad used to be my classmates' professors. Anyway, thank you so much for being here, and a couple of questions have been posed by the audience. One is actually by Dr. Anupam Agrawal. Is there any underlying defects, genetic defects in this study of yours from Andhra Pradesh because of a family history versus an environmental possibility of etiology?
Thanks, Dr. Chalapan, and thanks, Anupam, of course, for that question. I think I did partly address it during the talk. I very strongly suspect that there might be a genetic background as well. As a part of this project, we have actually collected blood samples and urine samples from these individuals, and we have created a huge biobank. And we are going back to these individuals every year and following them up for finding out what is happening to their health. So as a part of that work, we are indeed engaging in doing a whole genome sequencing in these individuals. Those samples have been sitting in the Institute of Genomics and Integrative Biology for the last 10 months. And because of the pandemic, that sequencing was not possible. But I'm very pleased to say that the process has now started, and we should know the answer to that question in the next few months. But thank you for that very important question.
Thank you. Dr. Jha, question from me. Actually, CKD is actually increasing, as you see in your diagrams and little cartoons you showed in Kerala, Tamil Nadu, Punjab, Goa, West Bengal. Now, and then of course, Punjab is also another one. Is this anything to do with the affluence or any other environmental cause which you think because they selectively, these have the higher death rate also? Obviously, if you've got a diagnosis, if they die, you want to actually relate to that. Is there any thoughts on that as to why these coastal belt on the east side having more, including Punjab, which is up north?
Right. So that's the $1 million question. Literally million, rather billions of dollars, need to be investigated in trying answering this question if we have to save money, right? There are two issues here. One is an issue of access. So if the healthcare access is better, you are even able to better count the deaths. And we know that healthcare access is better in the southern Indian states and in somewhat relatively affluent Indian state of Punjab. So more people come to healthcare facilities, more people are able to access healthcare, and they're counted as well. So paradoxically, in poorer states like state of Bihar and Madhya Pradesh and Jharkhand, etc., people may not even be going to doctors. And so those deaths are not even counted, which might be paradoxical, and the actual number of people with kidney disease may not be lower in those states. So that's something which is related to the way our society is constructed and the way people access healthcare. That's number one. Number two, of course, there are challenges and unique features for all of these populations. We did talk about the possibility of genetic clustering, and there might be some unique genetic factors which we need to identify. In coastal regions, as I mentioned earlier, there are potential unique factors. For example, high salinity. We have also shown that there is high salinity in coastal areas of Gujarat, for example, in Kutch, where the prevalence of hypertension once again is very high, and we are now going to start some studies there as well. The third place where we are finding now high prevalence of kidney disease is in tribal regions of Chhattisgarh. So there is a district called Supeveda, and we went there and worked with the All India Institute of Medical Sciences in Raipur and have shown high prevalence of kidney disease, and the government of Chhattisgarh is actually making some investments to find that. So while affluence does lead to increase in the prevalence of hypertension and diabetes, there are a number of unique kidney diseases related to deprivation in India, I think, which again is the kind of contrast that I was hoping I would be able to make in my presentation.
Thank you. Thank you for your erudite answer on that. We have a question from Bikram Paul. He says, what is the pathophysiology of CKD in type 2 non-insulin diabetes without hypertension?
Well, that's another lecture.
Okay. Is there any insights which you can throw a few lines for our audience?
Right. So in type 2 diabetes, it's been increasingly recognized that the classical paradigm of development of kidney disease through the stages of microalbuminuria, macroalbuminuria, hypertension, and then reduction in GFR is valid in a subset, but not all of the subjects. And the number of other changes also take place in individuals with diabetes, which can be possibly responsible for development of kidney disease. And they are related to changes in the tubular interstitial compartment, which could lead to development of kidney disease in a relatively silent manner, without development of proteinuria, and in some cases without development of hypertension as well. And there is a lot of research going on. I think we have Dr. Kasinath in the call, and it will be pretentious for me to actually talk about this in his presence. He would be the best person to answer this question, and you need to invite him to give a talk on this, I think.
You're absolutely right. I know about Kashi and his work on diabetic nephropathy. Thank you, sir. There's another question on SGLT2 inhibitors, which is not approved for type 1 diabetes patients when they get into kidney failure. Is there any helpful data on those populations with SGLT2?
Right. So it's very interesting. The SGLT2 has made such an excitement in the field of management of kidney disease, cardiovascular disease, and so on. And we are learning more and more new things almost on a weekly basis about what SGLT2 can do and how wonderful these agents are. So you are right that SGLT2 inhibitors have not been approved for in individuals with type 1 diabetes. But now we know that SGLT2 inhibitors favorably influence the course of individuals with chronic kidney disease, even those who do not have diabetes, right? So SGLT2 inhibitors might receive approval for management of kidney disease, provided enough data support those initial findings, irrespective of the presence or absence of diabetes, let alone type 1 or type 2 diabetes. So I think we need to continue to support the clinical studies and clinical trials that are ongoing. and watch the space of SGLT2 inhibitors.
Thank you. And the next question is posed on your data, which mentioned that the previous question was posed by Dr. Jogi Reddy Nareddy. The next one is by Sharma Prabhakar, who said that you mentioned 1 in 10 dialysis patients, ESRD, able to get renal replacement therapy. And they understand most of the nephrologists and the dialysis centers are concentrated in urban area. So your comment on the measures that must be taken to provide in the rural mass.
Yeah, excellent question. As I showed during my talk, we know that almost 25% of people who require dialysis need to travel more than 100 kilometers to get to a dialysis centers. About 50% need to travel 25 kilometers. So this is a big problem of access. Dr. Prabhakar Sharma is exactly right that most of the dialysis centers are concentrated in urban areas. So there are two things. One is that dialysis centers are now expanding to rural areas as well. And thanks to a lot of advocacy efforts, including efforts by us, and the government has been responsive, hemodialysis centers are being set up in rural areas, including rural areas of Uddanam, as I mentioned. But in 2019, recognizing this problem, the government of India set up a committee, which I had the privilege to chair. And that committee actually provided recommendations for setting up peritoneal dialysis programs supported by public funding. And now we are hoping that rolling out of peritoneal dialysis program will really democratize access to dialysis, including people in rural areas. Of course, providing peritoneal dialysis to rural population also has challenges, but those challenges are not ones that cannot be overcome, and the government and the communities are working on it.
A question for you from me is, as you know, the initiative in 2019 by the previous administration here in US had actually got into trying to get the kidney care in terms of peritoneal dialysis initiative from 5 to 7%. They wanted to get a penetration of 15%. Now, when you gave me the data from India, it was very kind of taken aback. As quickly you put patients on dialysis, there are a lot of people who drop out. What actually was the reason there? Because we are very big in PD in US, and to be honest, it is the best way to do rather than hemo if it is possible to use. So where exactly are we going wrong in India because of the dropouts?
Yeah, excellent question once again. And the most important reason for the dropouts is actually socioeconomic factors, because the cost of PD was not reimbursed until 2019, when the government actually allowed inclusion of peritoneal dialysis in the National Dialysis Program. So people had to pay out of their own pockets to access peritoneal dialysis. As you might easily appreciate, that initially people are enthusiastic about starting I shouldn't say enthusiastic, but they do want their loved one to not die because of lack of dialysis. So they put money, and very soon they run out of all their money that they have, and so they are no longer able to continue, and out of desperation, they have to stop dialysis. That is true even for hemodialysis. Just because hemodialysis treatment itself is free doesn't mean that all aspects of treatment of dialysis patients are free. For example, a dialysis patient needs to travel from his or her home to the dialysis center, and they need to travel 3 times a day. And typically a caregiver will also travel with them. They need to purchase other medicines, and all of this costs money. So there is a residual out-of-pocket expenditure, which is quite substantial for a large number of people, even when free hemodialysis is provided. So what the government has now appreciated is the need to also cover this out-of-pocket expenditure. And in the state of Andhra Pradesh, at least, again, thanks to the advocacy that we have done, the state government provides an additional subsidy of several thousand rupees every month to cover this out-of-pocket expenditure.
All right, there is another question which actually is thrown to the public at large and for you, sir, from Dr. Subodh Agrawal. Who actually should be responsible for the care of kidney disease, including dialysis? Should it be the individual or should it be the government? Here we have the Medicare, which regulates once you go on ESRD, and dialysis, we have the Medicare actually come into play, and that takes care of the payment in United States.
Yeah, that's a philosophical question because it talks about all healthcare, right? And we can debate this for a long time.
Sure.
But coming back to your point, Dr. Raj, as you say, there is no country in the world where dialysis is not funded by the government. There is no country in the world that has a sustainable dialysis program where dialysis is not funded by the government. If the governments do not fund dialysis, dialysis cannot be sustainable. That is a fact of life. Now, about the other aspects of healthcare, of course, the healthcare is a health system related issue and not an issue related either only to the government or only to the individual. So the entire range of stakeholders, including individuals, including communities, including government, but also many other stakeholders, which we don't realize. Many of our health challenges in future would be related to the way our cities are coming up. There are no green spaces in our cities, so people cannot undertake any exercise regime, etc. So I think it's a society-wide issue that we need to solve in a sustainable manner.
Thank you. There is two questions. I'll combine them together. Abhijit Goyal asks that is there any data on CKD that appears to be prevalent in certain areas? And the president, Mr. President, Dr. Sudhakar Janargada, asks, is there is a salt intake in the etiology of hypertension in these areas where we see the CKD?
Yeah, sure. So I think I did describe to you some of the high prevalence areas. So there is data on this. In terms of salt, yes, we do think that salt could be a culprit and more studies need to be done. Yes, so we have, so right now, as I said, we have collected their urine samples, so we have banked them. And currently we are in the process of doing salt intake estimation in all of these individuals by measuring 24-hour urinary sodium excretion. And so we'll be able to have a more granular insight into these ideas very soon.
Thank you. And there is one other question which says that resources are constrained. Environmental guidelines can be very useful. If anyone needs to look into the CKD guidelines, please let me know. And there should be hypertension and diabetic management also should be on the same line. So any initiatives being done in public education in these things?
A number of groups are engaged in public education, and there are a number of NGOs, non-government organizations. Government also is coming out with educational materials which are directed to the public, which are directed to stakeholder communities, etc. So there is a lot of work going on. We need to bring them all together and do a systematic program of work. We also recognize that the Indian population is so diverse in terms of language, in terms of culture, in terms of how they access information. And whatever education we do need to be culturally and contextually sensitive.
Thank you. That question was posed by Thakur G. Patel. The next one is from Abhijit Goyal. How can a deceased donor transplant rates be increased in India? Is there any central organization that facilitates the deceased donor organ allocation, such as UNOS and in US, as it is in US?
Right. So this is a live issue for the government of India. So there is a National Organ and Tissue Transplantation Organization, or NATO, which is the central authority for charged with regulating this. And there are state level organizations as well. And I have to say that the number of deceased donor transplantation has gone up quite substantially in some parts of India where this is much more organized. For example, in the state of Tamil Nadu, to some extent in the state of Andhra Pradesh, in Kerala and in Chandigarh, the number of deceased donor transplantations has increased quite substantially. And their model is now being increasingly followed in other states as well. And hopefully the number of deceased donor transplantations will increase.
I have a question on the term of toxicology. You know, when we go to all these, your review board series for nephrology, there is always a section on toxicology and kidney disease. And there is one proponent who always speaks from Miami, Florida, about all these Indian spices, which is contaminated with trace elements, cadmium, fluoride, arsenic pesticides, and of course, resulting in tubular interstitial nephritis. Now, where do we stand with that in terms of regulating these, or the levels which is acceptable, or which is considered toxic? And is there any truth to this? Because in that particular meeting, we as Indians we said, nah, we still going to use our curry powders and whatnot. So where do we stand with that, Dr. Jha?
Well, I'm not aware of any systematic study of spices. And I can tell you that any government that tries to regulate spices will be voted out of power in the next election. But there is certainly a documented contamination of many Ayurvedic remedies that are found in the market with heavy metals. And there is clearly a need to regulate Ayurvedic remedies for sure. Spices, that's a bridge that will be too far to cross.
Okay. Next question from Jitendra Kachori. Is there any polypill, ACE inhibitors and aspirin and statin programs in India and any role in CKD prevention?
That's a great question. So as a part of our program of innovative work, so there are three things. I think I showed you on one of the slides, but I didn't talk more about it. So we need to restructure the healthcare workforce by engaging more frontline healthcare workers. The second, I said we need to use technology more, which we are doing as part of our smart health work. And third is we need medication reforms. And we think that polypill is the way to go. And we are in the, we have already done a polypill trial. We did that in Sri Lanka and we published in the Lancet a couple of years ago. And one of our research fellows has just won a fellowship award in which he is going to trial a polypill for management of hypertension. And we are going to start with hypertension, and then we'll develop other polypills for management of cardiovascular disease and chronic kidney disease as well. We are working with Indian pharmaceutical industries who are, as you know, some of the world leaders in development of generic medicines. And hopefully that will open up a completely new area of therapeutics for the less privileged parts of the world.
Dr. Rani Reddy asks about the salt content in the water as well as the Indian food, and how will we regulate that, or education-wise, or is there any initiatives going on that side of the story, the salt study and hypertension, if I may add in?
Yeah, look, I think we did cover that partly in the in some of the questions before. So this is a live question, and high salt intake is not a unique problem unique to India. You go to China, you will find even higher salt intake there. So we need to come together as global community, and there is a big movement by Resolve to Save Lives, which was set up by Tom Frieden, of course, which is working in India also. So we are working with Resolve to Save Lives to develop alternate methods to reduce salt, and we are working on low salt substitutes. So low sodium salt substitutes rather. So low sodium salt substitutes are mixtures of sodium chloride and potassium chloride. And we are working with the government, we are working with other agencies to increase the uptake of low sodium salt substitutes. And because, you know, just telling people to reduce salt in the diet is not going to work. I have tried it on my parents and it didn't work, right? So that's an N of 2, but it's not something which Indians take very easy to.
The next question is a little bit intriguing because it applies to both in India and US. The First Lady of API, Mrs. Dr. Uma Maheshwari Jonalagada, asked, what is the reason for less nephrologists in India? And I will pose the same question, why do we have less nephrologists in US? We have an acute shortage right here. So anything comparing and contrasting the two?
Right. So less nephrology. First of all, India is a big country and there is a shortage of all specialists. There is a shortage of general physicians, not just nephrologists. So let's just put that into perspective. Having said that, the number of nephrologists is now increasing, and every year from the various training programs, the DM and DNB training programs, we have almost 100 new nephrologists graduating. This is a drop in the ocean and we need to have more, no question about it. But it is better than what it was 10 years ago or 20 years ago, when nephrology was a kind of backwater specialty, and most of the smart people would like to go into cardiology or gastroenterology or to surgical specialties. But that is now changing, and people are seeing nephrology as an important career field, and they're opting to join nephrology as well. As I said before, in the past, there are a large number of nephrologists, including, you know, many in the audience this morning, my time, who, because didn't find good career opportunities in India migrated elsewhere, including in US, and are contributing to the US nephrology workforce. As I said before, perhaps there are more nephrologists of Indian origin in US than there are actual total number of nephrologists in India. So that's something for you to chew on.
Well, may I just to make a comment on that? We have got a dichotomy where we have an academic and research wing of nephrology, which is more fascinating to the clinical side. And because of that, right now, we have an acute shortage of nephrology fellows. Their positions are not being filled. As such, we are not getting any clinical nephrologists out here. For want of time, I'm going to stop with two more questions. One is, I wanted to ask you, but somebody else has asked in the audience, Bikram Paul, any differences between the vegetarians and the non-vegetarians in the development of type 2 diabetes mellitus? But I will go a little bit further, as one study back in the late 80s and early 90s suggested that the non-vegetarians had a slightly few point lesser GFR compared to the vegetarians. Any knowledge to that kind of an information, which is authentic or not?
Yeah, look, so far as the vegetarian and non-vegetarian divide in India is concerned, I think that's an artificial divide, because most non-vegetarians in India, I count myself as a non-vegetarian, we eat meat maybe once a week, you know. So that is not someone that you will call a quote unquote non-vegetarian, except in a very, very puritanical Indian sense of the word non-vegetarian, that I don't even touch meat. You know, that's the language our patients sometimes use to describe their dietary habits. You know, I don't even touch meat, I don't even touch alcohol, etc. So, you know, even if we are non-vegetarians, we just touch meat. You know, so I wouldn't make too much of that, at least in the Indian context. About the Western context, I'm not sure.
Thank you. And last but not the least, from your good friend, Dr. Kashinath. That was a great talk. Vivek, Dr. Mani has started an effort to detect and manage hypertension in Tamil Nadu villages using the help of the village youth. He had employed inexpensive medications. Any comments?
So exactly, Dr. Kasina, thank you. So Dr. Mani, in fact, I would say in this sense was a visionary, that he saw this approach as being the viable approach, and he started this program. Unfortunately, that program could not be sustained, but I think that is the way to go, and that is what we are trying to do many, many years after Dr. Mani. But we are very conscious that whatever we do needs to be sustainable, and therefore, we are now employing the frontline healthcare workers, but also providing them with tools. We are making sure that medications that are used to treat different health conditions are available in the public healthcare sector rather than relying on charity. And the medications that are a slight difference, I would say, is that for Dr. Mani, cost was the only consideration, and he used medications like Reserpine and so on. But we think that it is important that we don't provide second-rate care to our patients, and that these patients should receive guideline-based care, for example. So we are ensuring that when treatment of hypertension is required, they are treated with ACE inhibitors and not with Reserpine or hydralazine. And these treatments are now available. ACE inhibitors are part of the essential drug list in Indian healthcare system. So it just requires some work to make sure that it is all available with the government.
I think that will conclude our question and answer sessions. But before I turn the mic on to the program director, Dr. Murthy, I wanted to just take this opportunity to thank you, Dr. Jha, for your time and for enlightening us on the global issues on chronic kidney disease. You have been, for the latecomers, Dr. Jha is the president of the International Society of Nephrology, the premier body in the field of nephrology all over the world. And in the audience, we have Dr. Anupam Agrawal, who's just been the past president of American Society of Nephrology. And interestingly, both your tenure crossed paths at one time. We had an ASN and ISN being actually head and manned by two Indians, eminent Indians. And we are proud of you, sir. And thank you for your service for us. And Dr. Agrawal, thank you for being there today. So, and with that, I would request 1 minute for the audience. Pause for a minute. Don't click the exit button yet. I want to tell two things. I just want to bring it up. Thanks to Dr. Vemuru Murthy. Dr. Murthy has single-handedly has given the time and his energy for this evening Wednesday session CME for the whole month. And he has chaired so many other sessions for API. We like to give him a round of applause. Everybody, by a show of hands, please give a big round of applause and thanks to Dr. Murthy, please. Now, last but not the least, behind the scenes of Dr. Murthy is Mrs. Vijaya Kodali. She is the lady behind all this and puts all the educational program so that it can reach us in a timely fashion. Vijaya, if you're not there, I would want to thank you for this. And with this, I would like to thank API for giving me an opportunity to moderate this session. Thank you very much. We have gone by 9 minutes past the hour. I'm sorry, Dr. Murthy. I turn the podium and the mic back to you.
Thank you, Dr. Alappan. I'm truly humbled and kind of embarrassed too.
No, you deserve it.
It is the teamwork, so it's not just a one man's performance. We are very lucky to have the leadership supporting, especially Dr. John Lagada this year for all the academic programs, and with the help from the Executive Committee, Board of Trustees, and eminent moderators like yourself, so it is a teamwork. Anyway, again, from the bottom of our hearts, we thank Dr. Jha for his precious time, and his message is very profound, and he's a man not only with a vision, but is also a man of action, putting the map of India differently, slightly higher scale from the perspective of the kidney health. And we were very happy to have him today. At this point, I request Dr. John Lagada to honor our distinguished speaker, Dr. Jha. Dr. John Lagada.
Thank you, Dr. Murthy. Thank you very much. Ms. Kodali, can you put the slide on, please? Dr. Jha, thank you very much for your time and for the enlightening talk on kidney diseases globally. And American Association of Physicians of Indian Origin recognizes Vivekananda Jha, MD, for his outstanding contribution to nephrology and welcome him as a member of API Distinguished Speakers Club. So Dr. John Lagada, President, API, and Dr. Vemuru Murthy, Chair, API Webinar CME Committee, February 24, 2021. Thank you again for joining us. Thank you, sir.
Thank you. You can all access today's program from the API website. So this officially concludes our CME program, and good night.
Yeah.
Thank you all and good night for being there today.
Bye.
Bye-bye. Thank you, Dr. Jha.